Welcome to Breakout Session 2, presented by Ms. Jennifer LaBay. Jennifer LaBay is an RN, an RAC Master Teacher, RAC-MTA, and CRC. Jennifer is the Curriculum Development Specialist for AAPACN, American Association of Post-Acute Care Nursing. If you do not mind, please help me welcome Ms. Jennifer LaBay. Jennifer?
Oh, that's fine. Hi. Thank you so much for having me here. I am from Rhode Island, so it's very nice to come to Tennessee because everyone's so darn nice here. Oh my gosh, it's lovely, not like snooty New England. So thank you for having me. As she said, I work for AAPACN, and if you're not familiar with AAPACN, we used to be ANAC. So a lot of people don't realize we changed our name a couple of years ago. And we still do all the same great things, but we're kind of expanding into more post-acute care. And not just what's going on in the SNF, although it's really the SNF and the MDS coordinator stuff that's our big thing. So Joel did a beautiful job this morning kind of prepping the overall review of the social determinants of health and the things that are impacting SNF QRP, value-based purchasing, all of that fun stuff. But now I'm going to dive into now, how do we apply that in the facility? Because we have new items coming on the MDS. What do we need to do to change our current process to make sure that we are addressing these things, that we're setting time aside, that the folks are trained, maybe things that we didn't think about of what we need to add to our current routine to make sure that we have this important information. Some of my housekeeping items, our objectives. As I said, we're going to go over all of these items and kind of figure out what do we need to do as a team. This is basically a slide that Joel already said. What are the social determinants of health? So we've got that same definition that he spoke about earlier this morning. And the different MDS items that we are going to be adding to the minimum data set. Minimum, I guess. It's not really minimum. So what are the things that we need to consider as a whole for all of these changes? We've got a lot of new data elements. CMS is kind of pushing, instead of calling them items, they're now data elements that we haven't collected previously. And operations managers are likely going to need to consider, how are we going to gather this data? Where is it coming from? How are we getting this information? Are we just gathering it on admission and expecting it to carry over from assessment to assessment? You can't do that anymore. This needs to be individualized assessments at each assessment. Who is going to be gathering this information? We can't just grab that information from the hospital or the transfer records and presume that it's accurate. We actually need to ask the resident these items because these are resident voice items. They're not scripted interviews like the brief interview for mental status or the patient health questionnaire, but these are resident voice items, and we need to make sure that we are indeed getting the resident's voice. So there are a lot of instructions in the manual as to how are we going to go about this. We start with the resident. What if the resident doesn't want to participate? What if they can't participate? And how are we going to proceed with that? So we need to make sure we understand what these items are. As Joel said, you really need to read that RAI manual. It's been out since April. We're expecting the final to come out. They were hoping early August. I'm getting an inkling that there's probably going to be more towards mid-August because AAPACN keeps sending questions to them. And they're like, well, hold on a minute. We didn't think about that. Oh, gee. So sorry. But we want to make sure that they have the most accurate information because, we know it's in the book, but this is what we're supposed to be following, but it's not always easy to follow, and sometimes a little muddy and sometimes a little gray. So we want it to be like, okay, boom, yes, this is this, or boom, that is that. So that could be why there's a little bit of a delay, but there's a lot of great information in that draft manual. So if you haven't started, I would dig into that. So where are we going to put this data? Is it just going on the MDS? Do we have to document it somewhere else? How is this information being collected? When? How? Who? The who, what, where, when, and why. You got to put on that detective hat and figure out these things operationally, so it's part of your policy or how you do things in your facility for collecting the data. A lot of this information for the social determinants of health is in Section A. Now, I don't know about you all, but when I was in the seat as an MDS coordinator, a lot of times Section A was just, oh, this is all going to carry over from some other part of the medical record, from the face sheet, the stuff that was, assessed on admission, and then it's just going to carry over and dump into everything, and I just have to click things so my name's attached to it so I can sign for it. It's not going to be that easy anymore. We actually have to do assessment. There are a lot of pieces of information that we need to gather. Who's going to be responsible for it? Is it going to be the MDS coordinator? Is it going to be the social worker? If it's coming from admissions, is admissions going to sign that MDS? So what are we doing? How are we getting this information there? And then making sure that the team is trained, making sure that they have that information. So how many of you all are MDS coordinators? And who else? Do we have DNSs in the room? Okay, some administrators. Okay, so we need to look at our process, and a lot of times we kind of just leave that to our MDS coordinators to, okay, well, here are the rules, here's the book, you need to know this and do your thing. But it needs to come higher too. We need to have that higher involvement, because if you have a policy in place that is mentioning things about Section A or Section B or Section D, and it doesn't reflect these new items, maybe you have allotted a certain amount of time to complete certain sections. Well, now it's going to take a little bit longer. So we need to consider these things. We need to make sure that we have all of the information. Like Joel said, CMS did a very nice job. They've really been doing a nice job of providing education and training. It's a little hard to find because they put it all on their SNF QRP page on CMS, but if you do a search on cms.gov for SNF QRP training, it will bring you to the page that has all of those YouTube videos. And in addition to the training that they just did this, over the past couple of months, they also have individual YouTube videos and web trainings on the different parts of the MDS that impact the SNF QRP as well. So they are to be used for all of the post-acute care settings. So take advantage of those resources that are there. And certainly AAPACN has tons of things available to you if you're a member as well. So you want to consider your policy impact. Is it new? Is it revised? Do we need to do anything? Do you have a policy on MDS completion? When I was in the chair, basically our policy was, we will follow the RAI manual. Okay, well that kind of covers your bases, because as the RAI manual updates, then we have to make sure that we're following that. But when it comes to actually doing it, we may need to look at things a little differently. So the first item is ethnicity, A1005. As Joel mentioned previously, this is a subject that we're kind of digging a little deeper into. It was race and ethnicity on the current MDS, and now we're looking at, and it is just looking at the Hispanic, Latino, or Spanish origin. And a lot of times there's been questions to ask, why is it just, there's other ethnicities out there. Well, I'm the messenger. This is what CMS has decided is the important piece to focus on at first. Who knows, maybe they will add additional ethnicities. But right now we're focusing, are you of Hispanic, Latino, or Spanish origin? This question should be asked of the resident directly. You want to start with that information gathering with them. If the resident is unable to answer this question, then we can go to others. Family, significant other, legal guardian, and we can ask them, but it has to start with the resident. So if the resident says one thing and the family says something else, we have to go with what the resident says, and that's what gets coded on the MDS. We always want to get that resident's voice. And we're going to check all that apply. And who determines what is their ethnicity? Whatever the resident says it is. If they say that they're Cuban and Puerto Rican, then they're going to choose C and D. If they are unable to answer, and then the resident's family answers, what you're going to check is unable to respond, and then the family's answer, which is going to be A through E. So those you can check, but then you have to be careful of why. So why is the resident declines to respond? When the resident declines to respond, they understand what you're asking, but they're saying, no, I don't want to answer this question. We can't ask anyone else. We can't use the medical record. We can't ask the family. Even if the family tells us, we can't code it on the MDS. Now, certainly, with all of these things that we're going to talk about, documentation in the medical record, care planning, items, certainly we can consider that. But for coding on the MDS, we have to follow these items. They really want to hear that resident's voice. And we're going to see this throughout a couple of these SPADES items, these social determinants of health. Same with race. A1010, what is your race? And this is going to ask the resident, what do they identify as? Check as many as apply. And it's that same idea. We're going to start with the resident, ask them if they're able to respond. You're going to check all that apply. If they're not able to respond, then we can go to others, the family member, significant other, a legal guardian. We're going to check X, and then we're going to say whatever the other folks say. But again, if we have that Y, sorry, I forgot my animation. If we select that Y, no other responses can be checked. Y is a standalone response, so your software is not going to let you answer it, even if you have an answer from an outside entity. So if they're unable to respond, we can ask the outside entity. If they're choosing not to respond, we can't go any further. So these are the things that your team members who might be asking these questions need to ask. If we're getting this information from our admissions director, how are they asking the questions, or are they just pulling it from what the hospital said? We need to make sure that they're actually asking the questions. And maybe it's not going to be the admissions director that's gathering this information anymore. Maybe it's going to be social work. Maybe it's going to be the nurse assessment coordinator, whoever it is. The government's not going to tell us who has to do it. We just need to know how to do it and what we need to do in our facilities to apply it. Our next item, A1110 language. So this is very similar to what we currently have. It's just kind of flip-flopped. What is your preferred language? You're just going to enter that in. And then do you need or want an interpreter? Again, this needs to come from the resident. And it's need or want. So if they want one, we have to provide that. So I'm a Boston Red Sox fan, and years ago, back when they were winning, they had a player who was, I believe he was Dominican, spoke perfect English, but he was a little bit arrogant. And one day he was having a snit, and he would not speak to the reporters, and he made the interpreter do it. So he did everything through the interpreter. He wanted, he didn't need it, but he wanted. So whatever the resident says they want, that's what we need to provide, because we need to make sure that we are hearing their voice when we're discussing healthcare decisions, having a discussion with the doctor, doing the interviews on the MDS, discussing the plan of care with them, discharge planning, all of these things. We want to hear the resident's voice. Now, just because we say that they want or need an interpreter does not mean we have to go out and hire someone. It can be the family, it can be staff, as long as they are doing a direct translation and not making something up because we want mom to look better because, we don't want anybody to think she's, got something going on. So this is going to be another situation. We start with the resident, and then if we're not able to get that information from the resident, then we can go to the family, significant other, legal guardian. And if we are not able to get anything from them, then we can go to the medical record. If we don't have any information about that, we're going to use the dash. Now, the dash is going to be that not assessed. CMS does not expect us to use it a lot, but there are some situations where we need to use the dash. Oh, me and my beautiful animation, and I keep forgetting about it. So what do we need to consider for these things? We need to do a facility-wide assessment to identify the interpreter needs of the facility. If we're in an area where there's a large percentage of a certain ethnic group or language that's going on, maybe we need to make sure that we have something in place there. Or maybe all of a sudden, in my hometown, when I was in high school, we had an influx of Ukrainians because we had a church that sponsored Ukrainian folks. So we all of a sudden had a huge influx and needed Russian in our community. So, looking at that facility assessment, finding out what do we have, what do we need, and then considering those unmet needs of the resident. And if that interpreter is not available, what are we going to miss? What are we not going to be able to understand or provide to those residents. And then we also want to consider the barriers to cultural considerations. If the interpreter is not there, if we don't know a lot about this culture, what is that going to do? We are supposed to, from regulatory, culturally competent care planning. That is huge. That and trauma-informed care kind of going hand in hand when you're hearing the discussion. They're two separate things, but that's what we're always hearing. This is part of that. We're going to see this drive. And as Joel said, with his little crystal ball, we're going to see more of it. I agree. I am with him in that crystal ball. There's going to be more of this. There's going to be more of this looking at the ethnicity, looking at the culture, making sure that we're addressing these things, and that it's not just up to, the standard white American male's view on the world. So we need to make sure that we're expanding. And this may impact accurate assessment. If we're not able to communicate with the resident, or the resident's family even, how are we going to provide the care? Sure, we could provide basic things, we could do observation, we could look at things, but how are we going to get that story? For me, whenever I'm assessing a resident, and it's been a while since I've done that, but what I want to sit down with the resident and have that conversation and find out, tell me more about yourself. Tell me what you like to do. Tell me how this impacts you. So we're not just looking at the clinical pieces, but something else that may be going on that we would miss if we aren't able to have that conversation. Do we have the opportunity to have an interpreter? Do we have staff that can assist us? Or do we need to maybe outsource? And then that would need to look at planning. Okay, we've got the interpreter coming in on this date. We need to make sure we're going to do the BIMS, the PHQ-9, the doc is going to be here. Maybe we'll have a care plan and make sure that we're setting that up so that discussion and communication can happen. And then looking at how are we currently assessing this? Again, are we just pulling it off what the hospital records said, or are we actually asking this question? And I still see this as a problem now. I mean, this question's been on the MDS for a while, but I still see kind of, it carries over from the hospital paperwork. We always are supposed to be asking this question. This isn't new, it's just kind of switching the focus as part of the social determinants of health and all that oversight. When looking at ethnicity and race, again, that facility assessment to make sure that we are able to identify what do we have, what resources do we have available, looking at those cultural preferences for care planning purposes, and looking at that staff training. If you have a certain percentage of folks that have certain cultural needs, does your activities department have things available to provide for that cultural need or difference? Or are we just providing, the weekly, Baptist service? Whatever it is, we need to make sure that we're looking at the entire facility as a whole and not just what the larger percentages. And I think that's kind of what the whole country is looking towards. We can't just be looking at that, one demographic because that's the majority. It's not everybody. We need to make sure we're looking at that, addressing the care plan. How are we gathering this data? Are we gathering it correctly? And then again, that staff training and education. Care planning to address the cultural preference. I kind of spoke about this already. We need to make sure that we have things in place. Maybe it's taboo to, direct care at the end of life, or some cultures may not want care provided by the opposite sex, things like that. And I think we've done a good job of doing that, but this is now putting it into, okay, well, it's going to be on the MDS now, and it's part of regulation, and it's going to be part of the survey. This is stuff we always should have been doing, and was always part of the care area assessment process, the REI process, but now we're adding more regulatory compliance and push towards those things. And this is straight out of the State Operations Manual, and this is not new language. There may be aspects of cultural preferences which impact the delivery of care, food preparation, so we want to make sure, if we've got a Jewish contingency, if they're kosher, we need to maintain those very specific rules, clothing preferences, hair covering, skin covering, physical contact, provision of care, cultural etiquette, avoiding eye contact, or, you go into a different country and you wave to somebody, and that could be offensive in that country, like, who knows? So we need to make sure that we understand those things. We want to consider, like I said, adding those activities that are culturally relevant, and any group activities with both sexes may not be permitted for that culture, so that's something that you may need to be aware of. Maybe there needs to be a women's only bingo, whatever it is you're doing. And then making sure that we are providing items in the residents' language, reading materials, newspapers. Do we have movies or television shows that perhaps are in their language. And again, the religious pieces and medications procedures. I mean, it's not just ethnicity, it could also be religious practices. Certain religions don't allow blood products or certain medications or things like that. So we need to be mindful of all of these things, culturally, ethnicity, race, language, religion, gender, sex. All of these things are just going to, I think they're going to be bigger and bigger and bigger as MDS 3.0 becomes 3.1, 2, 3, 4, 5, as they add more items, probably focusing on these things. The underserved is basically what we're looking for, is that underserved. So does that care plan reflect these things, essentially? Our next item is A1250 transportation. So what we're asking here, has the lack of transportation kept you from medical appointments, meetings, work, or getting things needed for daily living? This is only going to be completed on a 5-day assessment, on a discharge assessment, a PPS discharge assessment, and we're looking at in the past 6 months to a year. This may include time in the facility. We asked CMS for some clarification on that because there's some confusion as to, well, do you mean 6 months to a year? Do you mean 180 days ago to 365 days ago? Or do you mean like day of admission back 365 days? It's whatever the resident interprets it to be is basically what the government has told us. So we need to find out what kind of issues they're having. Again, this is stuff we should have always been doing as part of discharge planning, but now we're adding it into the MDS and making it officially part of something that we need to look at. And again, my animation, beautiful animation, wasted. So what we're looking at here, again, we have to start with the resident. And we start with the resident. Yes, it's kept me from medical appointments. Yes, it's kept me from non-medical appointments or other items, or no. Resident unable to respond, then we can go to the family, the significant other. If others are not available, then we can look to the medical record to see what kind of information. But again, if we use this why and the resident says, I am not answering any more of your questions, we can't go any further. We could care plan for it, but we can't code it on the MDS. So we need to make sure that we are following those instructions from the RAI manual. The rationale for this item is to make sure that we have good discharge planning in place. If we're going to have a plan in place for them to go out to appointments after they discharge home, if they're not able to get there, how are they going to meet those needs? So we need to make sure that we're looking at that. And then that could be part of the discharge planning with maybe using your local contact agency when looking at the Section Q items, which we're not going to talk about today. But that could be something that your local contact agency could assist with if we've identified this as an issue. So now we know we can't, they can't get to where they need to go. Local contact agency maybe can set up some sort of ride share or ride service, or they have something available that maybe we didn't know about. And making sure that we have that as part of that discharge plan. And the reason why we're addressing it at the beginning of the stay and at the end of the stay is because sometimes it's going to take some time to plan. So at the beginning of the stay, we know what the issues are, we can figure that out, find out what those resources are, and then that could impact the plan of care, say in therapy, or those other care that we're providing during the stay. Because that now we have to work on, oh, well, they need to be able to transfer into this vehicle because that's going to be how they transport. Or no, we're just going to do a wheelchair car and we don't need to focus on those things as part of their plan of care while they're in your facility. And then again, at discharge, because, well, that's when we need to actually do those things. I would imagine it's not going to change too much, but I guess it could. Because I always question, why do we have to ask this twice? But again, I am not in charge, I am just the messenger. So some operational considerations, maybe we need to consider how we do our admission assessment and develop a new questionnaire or adding a section to your current tools asking this information. And this could apply for everything. So who's going to ask the question? How and where will it be documented? Who's going to be responsible for this information in care planning and discharge planning? Who's owning this? Just because it's on the MDS doesn't mean that the MDS coordinator has to own this. So we need to look at it as a team and look at, okay, well, who's responsible for this? Who would generally ask these kind of questions? And then making sure they have the right information and we're all on the same page. Oh, I thought you were going to do that. Oh, no, well, I thought you were going to do that. So, we don't want to get in that situation because then we don't have the right information. And certainly, we can look at discharge planning with this, the care plan, your current policy and process. How are we going to make sure that we're addressing all of these things on that boots on the ground, in the facility, I have to get this MDS done, when are we doing it? And when are we assessing these things? So we have to make sure that we have a good understanding of the overall conventions of the RAI User's Manual itself. Unless it says otherwise, this information needs to be gathered during the observation period. So we're not going to wait until, okay, it's 7 days after the assessment reference date, and oops, nobody's done anything with ethnicity or transportation or anything. Well, oops, you missed your opportunity because it should have been assessed then. This is why we want to look at, well, maybe we need to assess this on that admission assessment, on that social history assessment that's being done during your observation period so you can gather that information appropriately. We don't want too many dashes because when we dash this stuff out, that's going to impact your SNF QRP program that Joel was talking about earlier. Health literacy is our item in section B, and we're looking at completing this on the 5-day assessment or our PPS discharge assessment. And we're looking at how often do you need to have someone help you read instructions, pamphlets, other written material from your doctor or pharmacy. So this is going to be a little different from the items that we talked about. This is only a resident self-report. We are not asking anyone else. We're not using the medical record. If the resident is unable to respond, they're unable to respond. If they decline to respond, they decline to respond. If they respond to us, we're going to choose rarely, never, sometimes, often, always. It's going to be whatever the resident feels it is. If they, well, what do you mean by often? Whatever you think I mean by often. Just like when we were talking about the pain interview, it's whatever you mean. We are not providing any definitions. But this one is different. We can't go anywhere else. We can't dig any deeper. Care planning wise, absolutely. Medical record, absolutely. MDS, nope, resident only. So health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information. Why do we need to know this? Well, for discharge planning, obviously, if we're, like was mentioned earlier, the big bucket of, I keep referring back to Joel because we're kind of piggybacking, the big bag of meds and the yellow piece of paper. Well, if they don't know what to read on that yellow piece of paper, how are they going to know any, you could have this beautiful discharge instruction, beautiful things written out, but if they can't understand it, it's going to be a waste. So we need to assess this. And from a care planning point, we may want to get, the family members' input on that because, maybe, mom's being a little obstinate and doesn't want to answer the question. I'm fine. Well, she's not fine. Well, care planning wise and discharge planning wise, yeah, we're going to have to address that. MDS wise, we have to code whatever mom said. So it gets a little tricky with this MDS. We have certain rules that we have to follow, which don't necessarily carry over into how we actually need to proceed with the plan of care or documentation. So similar to the language barriers, we need to make sure that this health literacy is not impacting their plan of care, their discharge plans. How are we going to proceed with things? Now, we always know that we shouldn't be talking to the residents in the gobbledygook of our language and PRN and BID, and we've got to bring it down to a level that they're going to understand. But even still, if they're having difficulty understanding those things, even if it's written out in a certain way, we maybe need to do something different. Maybe we need to make them a little video tutorial that they are going to have and they can refer to every time. Or, maybe they learn differently. There's different things that we may need to look at, and we're not going to know unless we actually assess what their needs are. So it's going to facilitate that better care coordination, the better discharge planning, all of those things. Again, stuff we always should have been doing, but now we have to put it on the MDS, and they're going to penalize us if we don't do it the right way on the MDS, but we always should have been doing these things. So for health literacy, how do we look at this operationally? Again, where are we gathering this information from? Where are we getting the social risk factors? How are we determining this information? Who's asking the question? Are we just putting it on a questionnaire and they have to read it? Well, if they're already having trouble not understanding, are we presenting this in a way that we care about their answers? So when the resident is being interviewed or asked these questions, is the nurse always looking at her watch? I gotta go give the meds, or I'm getting paged, I gotta go answer this. And then the resident's like, well, you don't care about what I'm gonna say, so I'm not gonna say anything meaningful because you just need to go do your thing. Set aside that time. Teach your team to set aside that time, make that person a priority in order to ask these questions so we can accurately put a care plan in place. Same with the scripted interviews. So, the BIMS, the PHQ-9, the pain. Show that we have that interest in them so then we can create a proper plan of care. So looking at these things, the health literacy, certainly how we provide that self-care. We talked about earlier the teaching and training, skilling for Medicare purposes, which gets totally underutilized. Maybe rehab uses it a lot, but nursing doesn't. Maybe we need to do more of teaching and training in a way that's going to be meaningful to that resident. Maybe not everyone's going to do well with a written pamphlet. Maybe not everyone's going to do well with I'll show and you repeat. We got to make it work for that resident, and we need to find out these barriers at the beginning of the stay. Because when does discharge planning start? On admission. We know this. This is things we've been hearing for eons. But now, we're following what we have to do, we always should have been doing, and it's got to go on the MDS. And if we don't do it accurately, we're going to get penalized. Not only are we going to get penalized from SNF QRP and all of those other things that Joel talked about earlier, but we're really doing a disservice to the resident, because now we don't have a proper plan of care in place. That was always the fun thing for me as a nurse assessment coordinator, was that deep dive care area assessments. Well, back in my day, they were RAPs, but back in the old days when I was doing all of this stuff, I just dated myself, didn't I? Whew. That's the fun part, digging and finding out all of this stuff and say, oh, this is what we can do for this resident, and this is gonna be fun, because I'm gonna be save the day, and I'm gonna be the superhero nurse who understands all of the things that they need and put the proper care plan into place. It was fun for me, but it helps you. The whole process kind of guides you through what you need to do if you don't know where to start. And again, goes back to training the staff. Whoever's going to be doing this needs to understand these things as well. Do they have the skill level to do this? Do they have the understanding of what the requirements are? Do they have the right communication? A lot of these things need to be considered. Maybe, you're not, your person who is brash and in and out and, not warm and fuzzy is not the right person to ask these questions. People have different personality things. It doesn't have to just be the social worker or the nurse assessment coordinator. Maybe you have a CNA who has a good rapport with the resident, and we could do some cross-training with them to get some of these answers, because ideally we want to hear the resident's voice and get that information. And again, policies and procedures, we need to make sure that we are up to date with those items and make sure that it follows what we're doing with the current RAI. D700 social isolation. This is again a direct report to from the resident. How often do you feel lonely or isolated from those around you? And we do have a definition. We don't have to give this definition. It's whatever if the resident says they feel lonely or isolated, even though they're having a party in their room every night, if they say that's how they feel, that's what we have to code on the MDS. Do further investigation. Care planning may say something different. But we have to address these things, because just because somebody's having a party doesn't mean that in their brain they're feeling, with all this stuff with COVID for the past 3 years and mental health and all, we really need to be more in tune to that and not just assume that somebody on the outside, this is what they look like and that's what's really going on in their head. So we really need to look at that and take it seriously and not just presume that, oh, everything must be fine because they always have people visiting and everything's good. Well, this is why we have to ask the question, and it's a resident information. Resident declines to respond, resident unable to respond, and again, that is that resident direct. We can't go anywhere else with this. This has to come from the resident. So this is going to be an actual or perceived lack of contact with other people. Tends to increase with age. It's a risk factor for physical and certainly mental illness. It's a predictor of mortality. So when we're looking at these things, and I think it's come to the forefront, like I said, with everything that's gone on in the past few years, how important your consciousness, your brain, your feelings, your mental health can have an impact on you. I was going stir crazy. Like I had my family, but it's like, I can't leave, I can't do anything. Whatever it is, that has an impact on you physically. So that if we catch this, we can have a great impact on that resident. So we want to consider how this data will impact care planning, discharge planning. If they're feeling lonely and isolated, that's going to potentially impact all of their care plans because they're not going to, I don't care. Whatever, that's going to lead to the depressive symptoms and I don't want to participate in this and we're not going to do that and what does it matter? That's going to have an impact on whether they're going to take their meds, whether they're going to do their exercises, whether they're going to follow through with any of their discharge plans once they, go home. And then if it's even worse, if they're going home and, they don't have anyone at home, they got the cat. I mean, the cats are great, but that's not necessarily going to help. But these are some of the things that we need to consider. Okay, well, what else can we do? What else can we provide? Are there services that in-house we can provide? Are there services, again, that local contact agency may be a great resource for you. Maybe it's not a medical thing. Maybe it's a loneliness thing. And just that little bit of assistance may be something that will help prevent getting to the point of clinical problems and, just sitting in one place and ending up with that pressure injury or whatever it is that might be going on. In-house, we could consider church groups, clubs, therapy services, and again, looking at what do we have currently in our policy and our care plan process. These considerations for self-reported social isolation, so this is from the National Institute on Aging. Find an activity the resident enjoys. It's not going to be, not everybody wants to go to bingo, not everybody wants to see the Elvis impersonator. What does that person, and then we have to consider the cultural pieces that go along with that. So it's kind of all encompassing. That's why they're all kind of grouped together with these social determinants of health. Find folks with similar interests and assist the resident to schedule time to stay in touch with folks that are important to them. If they want to attend an exercise group or a restorative nursing program, or they want to meditate quietly, or they want to have, whatever it is, this is where you really want to get that, that activity department, social, items, and focus more on the individual. Does the resident have a family, friend, or neighbor who can regularly check in? So for, either in-house or upon discharge, community-based support options, like I said, that local contact agency may have some things, and maybe not. Maybe it's not just the local contact agency. Maybe they belong to a church. Maybe we can get in contact with their congregation, and maybe they have some sort of, an outreach or something that can occur. If technology-based communication will be used and provide that training. A lot of these baby boomers, they have technology. My mom knows how to use an iPad. She's actually quite proficient at it. So, look at all of these things that we could provide. It doesn't always have to be the same thing. Let's think outside the box. 82121, provision of current reconciled medication list to subsequent provider at discharge. So what we're looking at here is that transfer of health information. And we need to make sure that that information is getting to that subsequent provider. In order to understand that, we need to know what those subsequent providers are. So that's going to be listed in that discharge status. And providing that reconciled list at the time of transfer or discharge can be by any means. So it could be by paper, it could be verbal, it could be if you have an electronic health record that you're sharing with that subsequent provider. We don't have to prove that that subsequent provider got the information. All we have to prove is that we provided that information. And when we're coding this, it's not the MDS coordinator who's responsible for providing this information. We're just looking at a process here. Did this process happen in your facility? So these are the different discharge, entered from and discharge status. A1805, A2105 have the same locations. So you'll notice there are some differences from what we currently have. When we're looking at the transfer of health to the other provider, we're looking at all of these items except for home or community. So when we're coding home or community, that means they're going home with no home health services. So if they're going home with home health services, we're going to be coding them as the organized home health service organization, or if they're going home with hospice, we would be coding them as hospice. So if we're sending them to one of those other 2 through 12, then we have to consider this. Did we submit this information? We should be doing it. We always should have been doing this. But now we have to have some proof that we did this. How did we do this? Did it happen? So we need to look at current applications for admission, make changes as needed. So if you have these different items as to where they came from, or maybe your discharge planning paperwork, where they're going to, maybe you need to update it to match what's in those current items. Any referral forms maybe need to be updated, data collection items or tools to include those additional items, and alert team members as to where the data will be kept and how to access. So if it's going to be that discharge nurse providing that reconciled medication record, where do we have proof of that? How are we documenting that? How is that nurse assessment coordinator who's filling out the MDS going to know that this was done? So we have to have kind of that cross-check and figuring out where are we going. Then we also want to look potentially at the status on the Medicare claim and make sure that that matches the status on the MDS. That might be something you want to add to your Medicare triple check process as well, because there is a spot on the bill that includes that discharge status and where did they come from, where did they go to. And then we're also looking at that provision of the reconciled medication list to the resident at discharge. So if they are going home with no home health services, then this is where we're going to, we may be doing it to both. If they're going home under home health, we'll give it to the resident and we'll give it to home health. We're only going to be coding the one of the provider. So it's not going to allow you to answer both of them on the MDS, it's either or. So if you're sending them home with home health services, we are going to be answering A2121, the provision, to the reconciled medication list to the provider, even though we may have already given it to the resident as well. So when we're talking about resident, it could be the resident's responsible party, whoever, the family caregiver, whoever it is we're giving that to. And these are added to meet those SNF QRP requirements that Joel talked about earlier. And this is, again, asking about that process. Did this happen? Do we have proof that this happened? So from an operational standpoint, we need to look at how are we keeping track of this. And then we also have to indicate, how did we do it? Electronic health record, health information exchange, verbal, paper-based, other methods. How did we carry this out in our facility? And then we have to, and again, we don't have to prove that the other entity received it or understood it. It's just asking with the process, did we do it? So we want to consider health literacy when determining the best route to provide the resident with the health information. If they don't understand, just giving them a copy of the MAR is probably not the best thing. Maybe we need to look at a different way of how to provide this information. How is the staff going to determine the best route based on this information? So it's kind of, it's a domino effect here. If the reconciled medication list was not provided, it's a best practice to document why. You know, anytime we're doing anything, if it's not documented, not done, we want to make sure that we have that understanding. And then consider how the direct care staff completing this task is going to do this. Do we have to update, like I said, the discharge packet, how we do things, what we're documenting? Is there something we need to add to our user-defined assessment in our electronic health record, or whatever it is that we're doing? How are we going to do this? And again, it's going to impact, just like we've been talking about, policies, current process, forms, care plan, discharge planning. We're going to talk a little bit about Section GG. This is not, I'm running low on time, this is not something that we're going to deep dive into, but just know Section G is gone as of October 1st. So GG is going to be the only way that we're going to be documenting that functional status. We have a couple of new items that are basically recycled over from Section G. Our functional limitation and range of motion, which is basically the same instruction, except for it's now in Section GG instead of being in Section G. And then we want to make sure that we're looking at all of the instructions. Like I said, if you're familiar with how it's currently being done on the current MDS in Section G, it's the same. For Section GG, we just want to make sure that we're not looking at the range of motion in isolation. But again, there could be changes with these things that are going to impact maybe your policy. So mobility devices, this is another item that is carried over from Section G, same items, but if your policy and procedure mentions Section G, you may want to update those to make sure that that information is now saying Section GG. Or if you have software that is referencing a certain item from, because I know a lot of those softwares will carry over stuff from MDS items. And if it's, you know, referring to Section G, it's not going to carry over anymore because there's not going to be any more Section G. So you may want to work with your software vendor to make sure that these items are in place. We do have an update into the self-care and mobility. We're now collecting the data on all OBRA assessments. So that is going to be collected in column 5, which was previously reserved for the interim payment assessment. Admission and 5-day, we have our admission performance discharge goal, and we have different assessment periods. So this will hopefully be a nice tool for you all to look at, because depending on what type of assessment you have, that is going to impact which days you're looking at. So we're only looking at a 3-day window, and depending, it's going to be 3 days at the end of the stay, the beginning of the stay, from the ARD. So hopefully this will help. So if we have a standalone PPS 5-day, that has not changed. Your look back period is the first 3 days of the Medicare stay, starting with A2400B. If we're doing a standalone OBRA admission, it's going to be the first 3 days of the stay, starting with the date at A1600, which is the date of entry. And if we have a combo platter, where it's the admission and the 5-day combined, your start is going to be from A2400B. So this can get confusing, especially if you're not used to doing that in all of these items. OBRA discharge, the discharge date, A2000 plus the 2 previous calendar days, a PPS discharge, A2400C and the 2 previous calendar days. And then again, if it's combined, we're looking at the Part A PPS discharge at A2400C. So it can get tricky. We need to make sure that however we're collecting this GG data, that we're collecting it so it meets these assessment period requirements. So that may mean adjusting how you're gathering that information, however you're doing that in your facility for Section GG. Interim payment assessment, assessment reference date, and the 2 previous calendar days, and then any other standalone assessment, OBRA assessment other than admission, is going to be the ARD and the 2 previous calendar days. Personal hygiene also is recycled from Section G. This is completed for all OBRA or discharge assessments. It is not completed on a standalone PPS. This is going to involve the ability to maintain personal hygiene, which includes combing, hair, shaving, applying makeup, washing, drying hands and face. Not going to include oral hygiene anymore like it does currently, because oral hygiene has its own Section GG item. Tub shower transfer, so this is kind of carried over from the G120, but this is just looking at the transfer portion. This is the ability to get in and out of the tub or shower. This is not the washing, the rinsing, the drying. We have another separate item for that. If the resident does not get into or out of a tub or shower during the observation period, we're going to use one of the activity not attempted items. So this is kind of a partial carryover from Section G. So what do we need to consider? Do our ADL flow sheets need to be updated? Are your CNAs documenting on any of this? Now, certainly there's many things we can talk about Section GG, but this needs to be a qualified clinician coding on the MDS, but we need to get some information from what is actually going on during the shifts. If your EMR software has solution built in, we need to make sure that that is going to be updated and who's going to be gathering this information. And if we decide that we are going to start having the CNAs document on Section GG, do they understand what it is? Do they understand what the definitions are? And it's completely different from what they already didn't understand from Section G. So we need to make sure that we're all on the same page and determine how are we going to collect this data for those involved in the resident's care, whether it's your CNA, nursing, rehab, interviews with the resident, interviews with the family. That is all part of that gathering of that information. And this may impact your policies. Your Section G language needs to be removed. You need to consider the education if you guys haven't touched GG at all, or if your CNAs haven't touched GG at all, or if people don't understand the new language, we need to provide that training as well. And certainly anything that's in our care plan that's in old G language, we're going to have to update to be GG language. So these are some things that, oops, I didn't even think about that. Yep, it's not limited assist anymore. We need to fix that. Documentation in the medical record is used to support assessment of coding Section GG. Data should be entered consistent with the clinical assessment documentation in the medical record. So we have to have documentation to support what was coded in Section GG. It doesn't say who needs to do it or when it needs to be done. We do have a question out to CMS because we would like some answers on that, because I know some of the managed care companies are a little persnickety about who, what, where, when, and when, why the Section GG information is documented. We don't have that just yet, but I'm hoping. And it's up to each facility how you're going to gather that information. But these are the things you need to look at. G, it's not going to be G anymore. And then we need to look at MDS scheduling considerations. If we're going to be putting out a schedule, when does GG need to be assessed? When is that 3-day observation period? Are we giving the team enough time to do that GG observation? It's likely going to be the basis of many reporting items and comparisons in the future, because this is it. So, look out. There's going to be more stuff related to GG. We need to make sure that the information is accurate, timely, done in the correct time frame. And then looking at this from a discharge planning standpoint, how we talked about this earlier. If they need to be able to transfer into a car, maybe we need to look at, is this going to be a car transfer? Are these things that we're going to work on? Are they going to use a personal car? Are they going to use a wheelchair? What do we need to work on during their stay? So that is, in a nutshell, broadly, all of those things. And there's a lot to consider. I mean, I could drone on for 3 days about this stuff. It's a lot of information in a short amount of time. So I'm happy to answer questions. I believe we have 8 minutes or so for questions if anybody has any information. I am super easy, like the doctor this morning. Email me. I am happy to answer any questions, provide, if you have scenarios. I'm not technically a consultant anymore, but I love fielding questions. So happy to answer any of those. And if anyone, I have a card if anyone does not have this. Any questions? Yes.
I'm back. Thank you, Jennifer. I just want to let you guys know, and your heads might be wheeling around from all this information on
I have that effect on people.
The changes, but if you want to get a hold of me, we have a culturally, linguistically appropriate service assessment. I have to slow down to say it. So a class assessment that you can do. It's voluntary. It's just coming to us. It's not going to CMS. We have resources already to help you on everything she just talked about. So from the admission process and identifying social determinants of health, health literacy, information on discharge that is built for health literacy needs. We have all the different languages on things. So again, if you guys need any help, please let me know. I talked to Jennifer. I'm going to email her the link to the class assessment if you want to look at it. It goes through the operational status, the communication process, and then how to sustain and improve as you work on that in your facility. So just wanted to let you know.
That's awesome.
If you let your QA advisor know, and we can ensure that you get that information too, if that's something that you're wanting from Miss Julie, we can get you connected. Go right ahead.
I wrote notes the whole time she was talking. So those isolation things that you were talking about, and we have a lot of residents that had got used to staying in their room during COVID, and they don't want to come out now, and they don't want to do any of the activities. How do you engage with them and help that feeling of isolation? Comfort menu, and I know you guys have one because you used it in opioid stuff. That stuff works really well for those residents that don't want to come out. So it's listening to music, having a book read to them, a warm cloth to wash their face. There's a whole bunch of things on that list. That has helped. And then the Center of Excellence, if you guys are not connected with them, that's through SAMHSA. It is a national project that's free to any long-term care facility. Again, you can get a hold of me and I can connect you with that organization. That will help teach your staff how to interact with patients that have mental health or substance use disorders. So again, a lot of things out there that we can help you with.
They have a lot of wonderful tools. They do. Yeah.
As we know, that's a growing population in our long-term care facilities, unfortunately. I do have a question, actually. Do the ethnicity and race questions have to be asked every assessment, or can they be carried over from assessment to assessment?
Yes, we had that question of CMS and we wanted some clarification, so we reached out to them, and yes, every single assessment has to individually assess those items.
Okay.
And, is it really going to change? Well, maybe the resident says it is, and so we need to assess it. So yeah, that's going to be a big change from how we're currently doing things.
And I have one more question if no one else has a question. Anybody? Okay. So what kind of documentation is needed for the CNAs to support Section GG coding?
Okay, so it's really, as I had mentioned, there's nothing specific from CMS that says the CNAs have to document on it, but they are the ones that are providing the care. So you need to look at it at your facility level. What is what do you want to do as a facility, or operationally looking at it from an organization if you're part of a bigger setting? What do we need to do? How are we going to address this? There is no requirement that Section GG is documented on by the CNAs. But if you are going to have them do that documentation, they're not going to be the ones that are making that determination of what gets coded on the MDS. But you need to make sure that they have the right definitions, that they understand what each of those items mean, what the partial, moderate, substantial, like all of these terms that you see, the CNAs have to understand. And like I said, we've probably had a hard time getting them to understand the Section G stuff. So however you gather that information, if you are going to have documentation, there could be some kind of flow sheets. AAPACN has some sample data gathering, but that's going to have to be in addition to that assessment by that qualified health professional and documentation to support what's actually coded on the MDS. That's where the documentation needs to come from, is from that nurse therapist who's looked at that 3 days, analyzed the usual performance, and made that determination.
Any other questions?
Sorry, you're stuck with me for the next session too.
I know, but I'm super excited about the next session too. So thank you so much, Jennifer. At this time, we're going to have a brief break. We will be meeting right back here again at 12:15 for Jennifer's second presentation. So we've got some drinks and some snacks back there for you guys to help you move through the rest of your day. Thank you.